All right. We all ready to get started here? I'm going to share my screen. Let's see. All right, everyone. Well, welcome to this first social media session for ASNC 2020. It's called Leveraging Social Media for Patient Care. My name's Brett Sperry. I'm a cardiologist, advanced heart failure and transplantation and nuclear cardiology at St. Luke's Mid-America Heart Institute in Kansas City. And I'm joined by a panel of excellent colleagues here, really with an amazing session here on social media and patient care. I just want to go over some ground rules. Initially, this is the webinar feature of Zoom, and so we have a chat function that you can see either on the top or the bottom of your screen, depending upon how things are set up. You can use that, the attendees can use that to chat with us or one another. And then there's also a Q&A feature on there where you can ask questions. We can answer them as panelists in real time, or we can save them at the end for the question and answer session to talk a little bit more there about those. Just some upcoming interesting sessions here in ASNC 2020. The full day of meetings are September 25th and 26th, and then we have these cases with the ACEs sessions on Wednesdays, which is really one of my favorite things about ASNC in general. So I'm glad we're having that available through the virtual format, thanks to some of our sponsors here. And I missed the slide about, let's see, here's the agenda, yeah. So here's the agenda today, and I'll start off by introducing our first couple speakers here. So Dr. Selma Mohammed is an advanced heart failure and transplant cardiologist at CHI Health, Creighton University Medical Center in Omaha. And with her, we're really excited to have Tanis Davis, who's a patient from Northern Virginia with a patient perspective on sarcoidosis, the benefits and risks of social media with respect to medical care. So I'll turn it over here to Dr. Mohammed and Tanis to lead us off here on this session.
Thank you very much, Brett. Good afternoon and welcome, everyone. It's my pleasure to kick off this session with our special guest, Tanis Davis. Tanis will share with us her perspective as a patient with multisystem sarcoidosis and how she leveraged social media to empower other patients and raise awareness. Welcome, Tanis.
Thank you for having me.
You're very welcome. Tanis, why don't you start by telling us about your journey and how you were diagnosed with sarcoidosis?
Sure. So I was diagnosed in 2006, quite by accident. I was having pain in my jaw, and they sent me for a CAT scan, and it showed nodules in my lungs. Excuse me. So we did another CAT scan, and there was nodules and inflammation in my excuse me, lungs, liver, lymph node, spleen, sinuses, and parotid glands, which was causing the jaw pain. So I was sent to a pulmonologist. The pulmonologist did blood work, and my ACE level was normal, so she told me that I had lymphoma. I had a VATS biopsy, which confirmed the diagnosis of sarcoidosis. So I went to another pulmonologist who pretty much downplayed the disease and said that I could go on about 6 months of prednisone and then just monitor me yearly after that. So I did go on 60 milligrams of prednisone for 6 months, and there was resolution in all of my organs except for a little bit of my lungs. So I had a CAT scan every year following, which was pretty normal. I still was living a normal life, very active. I did have a little bit of shortness of breath, but I do have asthma, so I attributed it to that. Then in 2012, I lost my father and my grandmother. And a couple of months after that, I started experiencing really severe symptoms of shortness of breath, heart palpitations, body aches, particularly muscle aches. So I went back to the pulmonologist, and she said she would be very surprised if it was the sarcoidosis acting up. So I found a rheumatologist who sent me to get a gallium scan, and there was quite a bit of inflammation and activity in my lungs. So he started me again on prednisone, 40 milligrams, and after 6 months, the inflammation was resolved in my lungs. However, I was still having pretty debilitating symptoms of shortness of breath, heart palpitations, fatigue, muscle pain. So out of frustration, I joined a Facebook group called Sarcoidosis Women, it was a private group for women only with sarcoidosis.
That's remarkable, Tana. So it seems like you've been through remissions and relapses with your sarcoidosis, and you had multiple symptoms that span different organ systems. So what was it like to join this Facebook group for women? And was it your first experience with social media, or have you had background about it?
I just use social media, in particular Facebook, just to contact friends. I had never used it for any medical reasons. So it was really life-changing for me when I joined the Sarcoidosis Women group. Very life-changing, very supportive.
Okay. All right, let's continue to hear your journey, Tana.
So I was doing well for a while, but continued to have the heart palpitations and decided to see a cardiologist. So she did an EKG, a Holter monitor, echocardiogram, stress test, and they all came back normal. So she was convinced that it hadn't affected my heart, but I just had a feeling all along that there was something wrong with my heart. So I asked her, please, to get me a PET scan, which she did. She ordered me a PET scan at a teaching hospital. And sure enough, there was activity on the anterolateral wall. So the cardiologist started me on Ventricular, 25 milligrams, and that was a bit too much for me, so they bumped it down to 12 and a half. I went back to the rheumatologist, and we talked about the importance of adding another steroid-sparing medication, which I wasn't happy about. I was fearful of. So we started on methotrexate, 5 milligrams. I did okay on it. I had a little bit of nausea. So we gradually worked our way up to 15 milligrams. So at that time, I was on 30 milligrams of prednisone and 15 of methotrexate and the beta blocker. I was doing pretty well, still having a few symptoms. We redid the PET scan in a year. It showed less inflammation, so that was positive. And then the second year, it showed more inflammation, actually, patchy inflammation throughout my heart. So they upped the prednisone again to 40 milligrams, and the following year, the inflammation was much better. So
Great.
they were on the fence about whether I should have an ICD or not, because I hadn't had any events. But I did go see an electrophysiologist, and he wanted to do an MRI and said that if we saw something on the MRI, that he felt that I should definitely have one for protective measures. They did see the inflammation on the anterolateral wall, which is probably now scar tissue, so he did recommend ICD. I've had the ICD since 2018. I was on prednisone down to 10 milligrams and still the methotrexate at 15 milligrams, was doing very well. So last year, after no incidents on the ICD at all, my heart rate was fine, my EF was fine, my PET scans were looking good. They agreed to take me off of the prednisone. That was extremely difficult for me once I got below 5 milligrams. Since I'd been on it for so long, I had headaches, nausea, but I finally did get off the prednisone, was able to get a little more active. I had osteopenia and gained 50 pounds, so they were anxious to let me get off of that. I was able to lose half of the weight. And then the following year, PET scan was good again. The ICD the readings were great again, so they reluctantly agreed to let me come off of the methotrexate. So now I'm off of the methotrexate, I'm off of everything but the beta blocker. I'm doing very well. I just had an echo that came out great, better than last year. I just have a little leakage on the right heart valve. Feeling pretty good, still a little bit of fatigue and body pain, but very stable.
I'm glad that you're doing well, Tanis. It seems like a long journey since 2006 until you were diagnosed with cardiac sarcoidosis, but you persisted and persevered and wanted answer for your symptoms. So kudos to you for doing that.
Thank you.
And tell us, throughout your journey, you've started with the cardiac sarcoidosis, with the sarcoidosis Facebook group, and then you later on became an admin for a cardiac sarcoidosis specific group. Do you want to tell us a little bit about this cardiac sarcoidosis group?
Sure. You know, being in these groups on Facebook has really been life-changing for me. I started with the sarcoidosis women group. I met a girl in there who had cardiac sarcoidosis. She lived in Canada. She was diagnosed a year before I was. So as soon as I got my diagnosis, she was the first person that I called. And she started a cardiac sarcoidosis group on Facebook, the only one. We have about 700 members now, and they're extremely supportive. It's a great information source for us to share treatments, doctors, advice, you know, emotional support for chronic illness, and that led me to FSR, and I joined FSR. I sponsored a walk for awareness in 2017, and then decided to be an ambassador for the state of Virginia in 2018, and attended a seminar, and Daniel Culver was speaking, Dr. Daniel Culver, and he talked about cardiac sarcoidosis and had some really interesting information with his studies. He was finding that up to 25% of cardiac patients, possibly more, our sarcoidosis patients had cardiac involvement. Before they were thinking it was possibly 2 to 5%. So he also was saying that most of the patients that he was finding with cardiac involvement were white males in their 40s, active white males, and that coincided with the cardiac Facebook group that I was in. The majority of the 700 are very active, physically active, healthy, 40 and 50-year-old men who have had events, 1 and 2 heart blocks before they were diagnosed with sarcoidosis.
Indeed, Tanis, indeed. It is underdiagnosed, and it's a challenging diagnosis, I would have to admit that. So from your standpoint and from what you've heard from your Facebook group, can you tell us more about what they felt social media has meant to them, other patients, whether cardiac sarcoidosis or sarcoidosis in general? And what do they find unique about it?
So for me, it's been life-changing just to have that connection, because it is a rare disease. When you think that you're healthy one day and the next day you have a disease that's potentially deadly, it's incredibly hard to deal with. So I actually took a survey in both of my groups, cardiac sarc and women's sarc, and across the board, they just said the support, that not a lot of family understands. We don't really look sick like in other diseases. So we get a lot of, you don't look sick, you might be lazy. But really the number one thing that everyone said across the board was that doctors don't listen to them, that they don't take them seriously, that they dismiss their symptoms. So they, we're asking for doctors sometimes to think outside the box and go the extra mile to diagnose symptoms that are unknown, and basically to listen, maybe do other tests that would help the patient understand. I know in my experience, I've been extremely lucky to have very good doctors that take a lot of time with me and explain things, and they treat me really well, so I trust them. And I think it's so important to have a patient-doctor relationship where there's trust, because once you have the patient's trust, then they're going to be compliant with their medication and treatments.
You have a great message for doctors, and I can't agree more, Tanis, that they have to listen to the symptoms, and not every patient is the same. And with sarcoidosis and conditions that are multi-system diseases, symptoms could just be highly variable and could be easily dismissed for something else. And maybe not knowing, reaching out and reading more and not settling for no answer. Wonderful. So with that, you have leveraged social media, you have empowered yourself, you have shared knowledge, and you have supported other patients and empowered them. How do you view physicians using social media, on the other hand, from your viewpoint?
So I think it's really, really important, particularly for advocacy, since it is a rare disease. There's not much on social media right now about cardiac sarcoidosis. When I was diagnosed, the only thing I could find was there was a 5-year life expectancy. So it's so important to publish studies, and also for support for patients and caregivers. Q&A sessions on Facebook or YouTube, like this one, are really fabulous. Patients with this disease are really hungry for knowledge, and especially those patients that aren't lucky like myself to live in an area where I have access to specialists who understand the disease. Even in other countries, our groups are worldwide, so there are a lot of people who don't have the access to specialists or good hospitals for treatment.
Do you see this as a two-way as far as research and dissemination of knowledge is concerned? Do you see that patients also participating via social media, which is something that challenges our current paradigm on how we conduct research and clinical trials, especially for rare disease? I mean, to your credit, you have a group of 700 cardiac sarcoidosis, which is enormous by all the means and the magnitude of what we know about this disease.
I absolutely think, like I said, my experience with them is they are hungry for knowledge. They're very involved in their care. They want to know more. They want more steroid-sparing medications. They really are willing and able to participate with any advice or any new treatments or research that doctors have done. Like I said, it's really isolating to have a disease that not too many people understand. So I think it's huge for the doctors that are doing research and the doctors that do understand sarcoidosis to make themselves available for the patients, like I said, who may not have a specialist in their area.
Absolutely, absolutely. Any closing remarks, Tanis?
Just thank you so much for having me. Like I said, it's so important. I feel like I'm speaking for all of the women in my group. I have 9,000 women in the sarcoidosis group worldwide and 700 cardiac patients worldwide. And they are all about advocacy and learning. So I appreciate this opportunity so much. Thank you.
Thank you very much, Dennis, for being with us today, and thank you for helping and empowering other patients and for sharing your story. It's very inspiring and very enlightening. I wish you the best, and thank you.
Thank you for having me.
Back to you, Brad.
Thank you so much, Tanis. That's amazing. I echo what Dr. Mohammed was saying as far as thank you for everything that you're doing for sarcoidosis. And you know, as far as social media is concerned, I do see a lot on sarcoidosis on Facebook, but we like to pull you over to the Twitter sphere as well to get more patient and advocacy groups in Twitter through sarcoidosis. So thank you for all you've done. I'm going to turn it over next to Dr. Jordan Strom, who is a non-invasive cardiologist at the Beth Israel Deaconess Medical Center in Boston. He's very active on Twitter and will be giving the next talk entitled "Case Got You Stumped, Social Media to the Rescue." I'll turn it over to Jordan.
Thanks, Brett, and thank you for Selma and Tanis sharing your wonderful story. So my name is Jordan Strom. I'm an assistant professor at Harvard Medical School and a non-invasive cardiologist at Beth Israel Deaconess Medical Center. We'll be talking today about the role of social media in case discussions. Here are my disclosures. So I think everybody here is privy to the fact that social media has absolutely exploded over the medical community within the last couple years. And in part, there are a lot of potential roles for the use of social media. One is for networking or opportunities, creation of opportunities. One is for organizations to help manage their own organization. Social media can be used for educational purposes, can be used for advocacy, and can also be used for journals or conferences such as ASNC to help promote their work. And this can be done across a number of different platforms, ranging from ones that are specific for medicine to ones that are not at all. And the newest kid on the block is now TikTok. So we have ever expanding means, and in fact, actually, there are several doctors now on TikTok who share their opinions about medicine. So in terms of the actual numbers and what's been looked at, worldwide, there are about 2 billion users of social media, so absolutely massive. Nationally, about 70% of Americans use some form of social media. If you just look within the medical community, if you look for MedTwitter, hashtag MedTwitter, which is a common hashtag used for to describe things relating to medicine, there are 4,749 publications in Medline from 2000 to 2018. So this is a widely exploding area. And if you look within cardiology specifically, and you look at, for example, the top line here, Cardiotrader, which is specific for cardiology, the total tweets number in the many thousands, and including the impressions in the millions and papers shared in the tens to 20s of thousands. So this is really, really an exploding area. And why would one join Cardiotrader? Well, one is, if you're a journal, for instance, you may want to increase the impact of your underlying work. And so this was a study that was done a couple of years ago and published in JACC, and that looked at the altimetric score, which is a sort of a composite metric of citations, but also references on social media, and looked at citations at 3 years. And there was a weak but present and strongly significant correlation between these two. The other reason to do this, and one that I'm going to talk mostly about today, is that the social media really presents a new paradigm for discussing cardiovascular case reports. The traditional cardiovascular case report would often take many eons to publish, would get into a journal, may or may not be read by individuals, and wouldn't have the same kind of interactivity that social media has. And the problem here is that clinical care is inherently delivered locally. And so that creates inequities in terms of clinical exposure to cases and also training opportunities for individuals involved. Social media, by contrast, democratizes the case report platform. It invites multi-specialty discussion and commentary of experts, but also commentary of non-experts and people who are deep in the weeds, treating patients on a day-to-day basis. Social media can reduce this knowledge gap from people who are actively researching these given areas through dissemination of expertise. It also promotes early adoption of techniques, and I think we've seen this with the rise in TAVR and structural heart disease over the last 10 years. In addition, multimedia can take what otherwise would be a paper non-static case and make into a really dynamic non-static case that people can interface with. So this is just this is ASNC, so this is just a little bit of a quiz here. And as you can see, Brett has posted something from the past here on the left here, which is an image of an FTG PET. And the question is, what is this FTG PET uptake, sarcoid, lymph node, or other? The answer was left atrial inflammation from a thrombus. And then Seth Uretsky posted about a 65-year-old male with VT, suspected cardiac sarcoidosis with late gadolinium enhancement in the base of the LV, which you can see here on the included CMR images. Really wonderful to see all the modalities together. And just shows that the PET CT did show avid uptake in the base of the LV. So other examples of things that you could potentially use social media for. This is a former trainee of ours who was posting about a unroofed coronary sinus, patient with an unroofed coronary sinus, and used polls. And so the use of polls really enhances engagement among people. It gets everybody involved and interested in the case. And it also collects sort of relatively representative, hopefully representative information on the people who are participating. This is actually the tutorial that was put out by Purvi Parwani, who's one of the leading experts in this field, looking at the paper that I just referenced earlier, the altimetric score. And as you can see, it is actually a series of tweets in a row that, although a shorter number of characters doesn't encapsulate the full complexity of the paper, bullet points of the relevant aspects of this can help people digest a very complex work in a very short amount of time. So tutorials can really highlight teaching points. This is an example from Nadine Faza, who posted a visual abstract, and visual abstracts are a single graphic that encapsulates a lot of information about a particular study or particular work, and can be really helpful to summarize the results, and those are gaining in popularity. And then, of course, you could use it for advice. And so this is somebody who tweeted the other day, I need your advice, patient with severe aortic regurgitation, not dilated, normal aorta, and aortic valve defect, fibrosis of the right coronary cuspis restricted, margin is thick and other cuspis normal. What is the possible reason? And as you can see here, there are 13 responses to this, and many people shared their ideas. And so this is sort of crowdsourcing expertise in clinical management advice. These are a couple of examples of my own. I think it's very, very helpful to use videos, because as we're all used to looking at non-static images, but really looking at videos, this allows you to, and allows others to really interpret the primary data for themselves to be able to really understand what's going on. And this is a case of a descending thoracic aortic dissection. It also allows for individual societies and other groups to be able to host Twitter journal clubs, which highlight publications and in particular allow for multidisciplinary discussion along those particular papers. So, but however, there are a number of downsides, and there are things that one should do for when sharing social media cases, but there are also a lot of things that are unfortunate downsides, but nevertheless important to consider when posting something online. And so one of the most important things is to maintain HIPAA compliance. And so you have to be a little bit careful with sharing rare presentations, because if the presentation is so rare that there might be only a handful of people with a given disease, they may be able to identify themselves via the images. And I'll show you some cases of where that was an issue in the past. And whenever possible, it's really important to try to obtain written or verbal consent from the patient where possible to share their images and to share their story. As with everything else in a profession, just because we do it online doesn't necessarily mean that we should break down the barriers of professionalism. We have to maintain professionalism by both your own institution's code of conduct, but also a professional code of conduct. You want to maintain a public face to both society and the patients that are actively looking at your tweets and reading this. And have some decorum with other members of the medical community. We may disagree on individual things, we may disagree on science, but at the end of the day, we're all still part of the same community trying to strive for the same purpose. Plagiarism is still plagiarism, even if it's online, so important to avoid that. And then have to be a little bit careful in terms of how you couch recommendations to people. You can't recommend necessarily medical advice if you're not the treating physician. So that's something that's important. And similarly speaking, people, I think, sometimes get caught up in this idea that they can potentially answer a medical question. But remember, there's lots and lots of physicians on Twitter who have a variety of medical specialties, and it's important not to operate outside your specialty jurisdiction, because your specialty jurisdiction still applies online. So this is a great article I would encourage everybody to read if you have a moment by my research mentor, Bobby A, talking about academic cardiology and social media, navigating the wisdom and madness of the crowd. And I think it reflects a lot of the things that I also say to people when they ask me about social media, which is you have to be careful about the outsized influence of a tweet. I say to people, if you don't want to announce it in front of a lecture hall, don't say it in a tweet, because functionally, if you have 5,000, 6,000 followers, you are announcing it in front of a lecture hall. Be careful sharing non-evidence-based opinions. Patients and other medical professionals are listening, and they may latch on to those opinions and think that they're fact. And you have to be wary a little bit about alienating the quote-unquote silent majority. There are a number of people on social media who are listening to conversations but don't necessarily engage in the conversation. The goal is to really try to engage others in conversation, and not to silence dissenting opinions, but to welcome them and to try to engage them in a conversation. Another challenge to social media is in this era that we have of post-fact, who is the ultimate arbiter of social media truth? At the end of the day, somebody comes out and makes a statement, there's often not that same kind of fact-checking or peer review that happens with published papers. And so things can be said that are not necessarily factually correct. The other thing, and this is, I think, relevant for all of us who spend a lot of time on social media, is you have to be careful to manage or budget your time. On average, people spend an average of 153 minutes per day on social media in 2019, so it can really be a time sink. This is just one paper that I saw from Circulation that looked at 271 healthcare worker blogs and looked at the degree to which they mentioned things that may be considered not especially professional. So 42% described individual patients, 17% in fact included sufficient info for patients and family to actually be able to identify themselves. And 3 of those blogs actually included recognizable patient images. This can be a real problem. And so why is this a problem? Well, this gets out there. These are a couple of cases of things that have been mentioned or have made their way to the media. So this was a Rhode Island doctor. This was from the Associated Press, a Rhode Island doctor who inadvertently identified a patient through a Facebook post. She actually didn't include the patient's name and didn't intend to reveal the patient, but the patient had traumatic injuries that were identified as such. And so the patient was reprimanded and ultimately had to pay a fine for that. And this is perhaps in a little more extreme case. This is from San Diego, a hospital who actually fired several of their workers for sharing and posting information on social media that caught the attention in the state. And one of the points here is that if you're sharing, particularly on Facebook, Facebook data use policies allow Facebook to share your information in response to a legal request. And so if you're sharing on the Facebook, you should consider that that information is out there and should be and can be shared and can be called upon in the court of law. So what are the do's and don'ts? So what do we want to do? Well, we want to state whether or not You want to state whether or not you're representing your employer or institution or not, and if you're representing your person. You want to follow my ASNC. You want to use hashtags. Things like hashtag CVNuke, hashtag ASNC 2020 can really help people follow the conversation along. If you're going to be sharing images, share de-identified images and interesting cases we want you to share. Create tutorials, visual abstracts, polls, engage people in your posts. Use multimedia. Try to engage the people who are not necessarily responding or active in social media. And in turn, follow social media influencers. Read up on what's going on in the field. This is a fantastic way to learn and find out what's going on in the field. That said, what you don't want to do is engage in unprofessional contact or spread false information. Communicate with patients on non-encrypted social media platforms. Post things that could be potentially used to identify a patient. Accept a patient quote-unquote friend request to communicate about clinical management. Hide financial or non-financial conflicts of interest. You have to be a little bit wary of individuals who don't disclose conflicts of interest, as they may not be disclosed online and there's no laws to say that they need to be. And don't be anonymous or hide your credentials. If you're going out and making a statement, stand by your word. The other thing not to do is to give medical advice. I think that goes without saying. So I conclude this by saying, is it social media to the rescue or social media to the rescue, question mark? I think it's a little mix of both. Social media is a wonderful democratizing force that can help bypass traditional hierarchies, crowdsource case reports. Inclusion of multimedia can help highlight a tweet and promote attention. It could also be potentially harmful to your reputation and career if used improperly. So guidelines ultimately for social media use are needed to be able to help encourage appropriate and meaningful dialogue amongst cardiovascular imagers and other health professionals. And with that, I just wanted to leave this free online course that is offered by Mayo, the Mayo Clinic on social media basics for healthcare professionals navigating the regulatory and privacy concerns. It's a great course. I've taken it. Our institution actually requires it for anybody opening a social media account. And I think it goes over a lot of the basics of these platforms. So with that, I'd like to thank everybody involved. We'd like to thank ASNC and for having me, and thank Brett for moderating this. And we'll turn it back to you.
Fantastic, Jordan. Thank you so much. A lot to think about there with the do's and don'ts of social media. I definitely bookmarked that slide to use in the future. Good transition with Mayo Clinic as well, because our next speaker, we have Niti Agarwal, who's a cardiologist at the Mayo Clinic. She's also the vice chair for the social media task force here with ASNC, and will be speaking next about staying abreast, traditional learning versus the Twitterverse. Turn it over to Niti next.
Thank you, Dr. Sperry. Good afternoon, everyone. It is a real pleasure to be here. I have no financial disclosures. However, I am a little bit biased because I'm the social media editor for Journal of Nuclear Cardiology. I am the social media track chair for ASNC 2020. And I'm a Star Wars fan, and you'll kind of see that bleed through in the presentation. So 3 days ago, over Labor Day weekend, I was perseverating over what to put on this talk. And I decided it's a Twitter talk. Let me go to Twitter for help. So I posted this image and I asked people to post examples of how social media has helped your learning. And in response, within the hour, I had 9 responses from people that pretty much created my talk for me. And I'd like to devote my talk to these autographs, as we call them, and many, many more people that responded after the first hour and retweeted my tweet to spread the word. And the other thing that is important about these people is they're covering a vast expanse, not just in the United States, internationally, across many fields. We've got an interventionalist, we've got electrophysiologists, we've got people that are non-cardiologists. And it is also fascinating for me that some of the people here were people I knew, followed on social media, and were good friends, but there were people that I had never met that came to my rescue. In the current era, we're all enamored by competing time commitments, expenses, and now COVID, which prevents us from attending conferences live. It's also hard to keep up with journals and guidelines, and textbooks often get outdated. So what we really need is we need to find a way to go from this absolutely overwhelmed state, funnel it down, and release little nuggets of knowledge, perhaps bite-sized 280 character summaries, i.e. tweets, tutorials, polls, journal clubs, and finally podcasts. And this to me is the true power of social media or Twitter. The tweets and messages we send out on social media by definition are concise. They allow for inclusion of multimedia format that is not always feasible with other traditional journal sources. They tend to be interactive, learner-centered, allow for rapid real-time dissemination. They have a worldwide reach. We get instant global feedback, collaborative, allows for a multidisciplinary team, as you saw in that little experiment I did. They're free of charge and no travel required, which of course is important in the current era. I did another experiment. Well, sorry, this one is a tweet from our virtual moderator, Marin Shetty, who posted about a week or two ago, who is the father of diagnostic nuclear medicine? She also posted the response as Dr. Blumgard and posted a little historical nugget. This is often what we see at conferences and meetings where it tends to be boring. Even Master Yoda would say, boring this meeting is, sneak out you must. When we Twitterize that, we see images like this that make the meeting a little bit more lively and interactive. When people tweet, they're learning by teaching. It forces you to condense ideas and improves your retention. Here's an example from ASNC 2019, where Dr. Abu Azzedine, one of the amyloid experts, posted, not all ATTR glitters is gold, meaning referring to the false negatives, the early disease, and the late imaging. And not all that glitters is ATTR, referring to the false positives, including AL amyloidosis, pericardial effusion, breast implants, hydroxychloroquine toxicity, rib fractures, and recent myocardial infarctions. So as a second experiment, I also posted on Twitter and asked the Twitter crowd, how do you learn? Within 24 hours, I had over 150 responses where almost 60% of the audience said over Twitter, and there was about 35% that said journals. So talking about journals, of course, your favorite journal, Journal of Nuclear Cardiology. You want to read JACC Imaging, JACC Heart Failure, and of course the original JACC and all the other JACC family of journals. Same thing with circulation. You've got a huge family of circulation journals. You've got Society of Cardiac MR, you've got JAMA, you've got New England Journal of Medicine. And prior to me joining Twitter, this is kind of how I felt. It was hard to keep up. I felt overwhelmed. Many journals, including the Journal of Nuclear Cardiology, have open Twitter accounts and generate tweets to curate content. Here's an example of our recent GNC tweet, where we say quantitative thresholds for FDG PET are recommended and improve diagnosis of sarcoidosis. It's a 280 character summary of the whole article. And then of course, if we're interested, we can dive in deeper. As Jordan mentioned, we also do tutorials, which is nothing but a way to string together multiple tweets. So in the peak of the COVID pandemic, the ASNC released guidance and best practices for nuclear cardiology laboratories during COVID-19. The tutorial highlighted the importance of rescheduling all non-urgent studies, promoting telehealth, and using rapid protocols. And of course, to screen prior to arrival, or screen patients prior to arrival, and ensure that symptomatic patients do not get into the lab. Journals also do journal clubs, as is mentioned by one of the influencers, Gina Lundberg. She mentions that journal clubs have no geographic barriers, allow for asynchronous discussions. There are clear metrics of success, but of course it requires time, and upkeep commitments. You can also have podcasts, and JNC does do a podcast every month, and you're welcome to go to the website and watch these. Then there are late-breaking clinical trials where you feel like you're overwhelmed with pages of information, but Twitter can Twitterize these into 280-byte character size knowledge nuggets. As a recent example, just last week at ESC, they released 126 dense pages of text on the atrial fibrillation guidelines. One of the leaders of Twitter, Mama's Mamas, posted AF guidelines in an easy to remember format, as easy as ABC, with a nice catchy image, and that helps us gather the salient features of the guidelines. As another example, with the posting of the ischemia trial, Chiara Buccarelli from Society of Cardiac MR posted, myocardial ischemia is still important after the ischemia trial. There are some major limitations, and we need to avoid extrapolations. She talked about coronary anatomy not explaining symptoms, stress tests conferring prognosis. It's a class 1 indication to either do a cardiac MRI, echo, cardiac CT, or a nuclear study, and that there is no perfect test. Others, such as Viet Lee, talked about the application of the ischemia trial. And then, of course, there were people like David Maron, who was part of the ischemia trial that gave his own rendition of the ischemia trial literally in music. I could go on and on about the ischemia trial because, frankly, Twitter went on Twitter storm. But it's important to control the socialness of social media. As Jerry Master Yoda would say, you will find only what you bring in. A good friend and colleague I met on Twitter, Anastasia, says, your world is a reflection of yourself, meaning we all like to see selfies, and it's easy to get caught up in the selfie moments. But be careful about your network. If you're only following people that are posting selfies, that's all you're going to get out of Twitter. If, on the other hand, you have a good mix, perhaps sometimes you're posting selfies, but at other times the people you're following are posting more educational material, your Twitter experience is going to be more educational. So control the socialness of social media. It is definitely beyond the likes and the retweets. Jordan mentioned a little bit of this data, where greater than 90% of the physicians use social media for personal activities, and about 65% use it professionally, and these numbers are definitely increasing. We've talked about so far how physicians use social media to educate each other and spread awareness, but they can also use social media to promote patient education material. The prime example of this is Cardiosource. And then it can be used for public health campaigns that we saw during the COVID-19 pandemic, including social distancing, masking, hand washing, etc. And from a patient perspective, 8 out of 10 US internet users search for health information online. Of these, 74% use social media. So of course, our patients are on social media, so it's important, as our patient Tanis mentioned, to involve them. Social media or Twitter is not all good. There are some perils. Many of these were already mentioned by Jordan again. You want to be thinking before you post. The information on social media can often be of poor quality. It is not peer-reviewed. It's not always a credible source. It's often unreferenced, superficial review, as we saw with the guidelines. Just getting a 280-character summary may sometimes not be enough. There may be special nuances or situations that require you to dive deeper into the guideline and actually read the text. Often these are opinions and not guidelines. As previously mentioned, your network is important, and being cautious about who you are following and where you're gathering this data from. You want to create a deliberate persona and stay professional. Sometimes it can be a time sink. And again, you want to be careful. If you're just going on social media for the socialness, it will definitely feel like a time sink. I can speak from my experience. Prior to being on Twitter, I used to feel overwhelmed. I would spend a lot of time trying to keep on track of journals, but it was a failing battle. Since I've joined social media, I have a close track on my network, and now all the articles I want kind of come through to my Twitter feed. I then take the time to go back and read the articles that are of relevance. And in the process, now not only am I up to date on my articles, I actually feel like I'm saving time. And it does have an impact also on mental health. For a lot of people, they get positive reinforcement from the likes and the retweets. For others, the absence of the likes and retweets can make them feel socially disconnected and have a negative impact on their mental health. As Jordan mentioned, do not breach patient privacy, be respectful of plagiarism and avoiding copyright infringement. And remember, it is often not as valued for academic promotion. So to me, it's a fine balance between traditional learning and Twitter learning. And perhaps you don't have to choose one or the other. For me, being on Twitter allows you to enhance the traditional learning. So feel the force around you. Go ahead and join Twitter. I'll be happy to take questions, but the answers might be better available on Twitter. Thank you, everyone. And back to you, Brett.
Fantastic. Thank you, Niti. I think, yeah, I would absolutely second everything you said. I think joining social media for me has certainly led to being able to keep up to date with current research and with everything going on, while not feeling bogged down to have to pick up physical journals and read them cover to cover. So thank you for going through all that with us. Now I'd like to reintroduce Dr. Selma Mohammed, again, advanced heart failure and transplant cardiologist at CHI Health, Creighton University in Omaha. She'll be speaking here about advancing your clinical practice across the Twitter sphere. A slight change in focus here in the next two talks on building your clinical practice with respect to social media as a physician. Your audio is off. Yeah. There we go.
Thank you, Brad. Hard acts to follow, Niti and Jordan. So I'm going to focus my talk on more of the clinical practice aspects of this. Trying to move my slides. Here we go. Okay, I have nothing to disclose and no off-label use. All right, so I view this as 5 points, and this is again my viewpoint. This is not supported by any data. One is strategy, and this covers 4 of the 5 points. And the second is activities, which is the 5th point. So for the strategy, it's a series of questions for every user as to what is it that they're trying to accomplish and why they're choosing this platform and who they're targeting and what their metrics are. So before you start, ask yourself these questions. Why Twitter? What are your goals and metrics? Who's your audience? And when is the best time to reach your audience? And once you have these questions answered, then you can translate this into activities and how you can actually do it and accomplish this and reach your audience. So why Twitter? Twitter is very popular, and it's basically what's going on around you. And this is right from Twitter. When you log in, you'll see these 3 things on Twitter screen. Follow your interests, hear what people are talking about, and join the conversation. So Twitter inherently revolves around conversation, and it's very humanizing to have that platform. It has over 300 million active users and counting. So you have a huge reach, and the sky is the limit for you to have an audience. It's best for public relations. And again, this part sort of goes along with the conversational aspect and what makes it more humanizing, because people want to want to relate to someone, want to talk to a person and not necessarily an organization. And it's a very powerful marketing tool, whether this is for your own clinical practice or whether it's for yourself and your career. Okay, so setting your goals. First, you have to establish what brand you are. Traditionally, the model that we work in has focused on the tripartite mission, whether you're a clinician, an educator, or a researcher, but a lot of us are clinicians by heart, and they also have an additional component to that, whether this is education, research, and now becoming more popular, having social accountability or community engagement interests. So identify that, and you can identify an area of niche in addition to this so that you have something that's unique about you. And if you're not sure about it, this should not preclude you from being part of Twitter, but always think of this about defining who you are and identifying your brand. And this way you could link it to your role as a clinician. Another goal would be if you just wanted to connect with like-minded professionals or people who have similar practices as yours, exchange ideas or best practices for better care for the patient. So any of these are altogether could be accomplished through Twitter. The final bullet point is whether your goal is purely marketing for your practice to acquire and retain patients. And I would say this is extremely difficult for an individual to accomplish because there are so many strengths attached to it. So if this is your goal, I think it's best to partner with your organization, marketing, or digital media team so that you're covered and you're not getting into issues about this, especially if you are using material that relates to patient stories and such. So it's better to stick with your role as an individual within your practice and not so much a pure marketing. So depending on your goals, then you have to define what your metrics are, because if you're using a platform, you're spending time on it, you want to know what comes out of this. It could be simply engagement, like how many people have liked your tweets, your replies, or retweets. And this may or may not necessarily be all, because people may like for a different reason or retweet or not retweet for a different reason. And again, it's also dependent on the number of followers and things like this. So you have to also take it in context when doing interpretation, especially early on in your Twitter career. And Twitter does provide analytics for you, which is helpful, so you can check from time to time. To also be followers, there's a great emphasis on the number of followers, and there is something to say about the number of followers, but again, I would say it's not the number of followers per se, but also the quality of your followers. And also don't be hard on yourself if you're just starting. You're gonna build up your followers, and it will take time and persistence. Your metric could simply be process improvement. So you're coming into it from a clinical practice perspective and you want to learn something, take it back and help improve your practice, learn knowledge from individuals or vice versa, bring something to the table, share what you've learned from your own practice, and others might benefit from it and have their practices improved. Patient referrals, this may be based on your unique expertise on Twitter or patients just knowing that you have something to offer coming directly to you or being referred through colleagues. But again, the majority of this comes from your main healthcare system or your main hospital Twitter website. This will have more information for that purpose. And it could be intangible. There may be much more that you could get from Twitter by virtue of being part of the community and participating. So whatever it is that is meaningful to you as a metric of success, you have to identify this. So you're not just spending time on Twitter, not really having a goal, not really knowing where you're going and what you're getting out of it, because our times are precious and we want to make sure that whatever we put into Twitter, it pays dividends back. Your audience. So your audience could be physicians, or advanced practice practitioners, pharmacists, nurses, etc. Or it could be students if you're more of an educator, gearing your tweets towards trainees or students. It could be other healthcare professionals. For example, if someone is at a healthcare policy level or public health perspective, or healthcare determinant or community engagements, this will be a level where you would want a broader sense of professionals. So it could be patients and caregivers if you're focusing on initiatives that are targeting patients directly, or it could be the general public. And this is along the line of thing that could be useful to anyone regardless of their background and or their knowledge base. So the best timing to reach your audience, this relates to the timing of the day or the week, as well as the timing of the event that you're tweeting about or whatever it is that you're tweeting. So if your tweets are coming after an event that you've experienced, you want to share a story of something that you find helpful or inspiring, it's best to do it right away. If it's an event like a scientific meeting, they've learned something that's helpful, also strike the iron when it's hot. You can't come back 2 weeks and write about Emperor HF trial after there have been hundreds of tweets about it, unless you have something that completely new and add to the table, because you sort of have lost momentum. I think the best is to have things tweeted right there and then. The timing of the day will also depend on who you're targeting. In general, for cardiologists, everyone is working, so early in the morning, early in the evening, before people go to work or after work, because we rarely have a chance to check our Twitter account throughout the day when we're busy seeing patients or doing other things. The weekend could be variable, but again, there's no perfect timing. It just depends on who your audience is and what you want to tell them about it. So now you have a strategy. You've decided what your goals, what your metrics, your audience, how you're going to target them, and when you're going to target them. It comes to the actual work that you need to do to get your tweets out. If you're ready to go with your tweets first, you have to pay attention to the aesthetics. It plays a huge role. It does not overcome poor content of your tweet, but it does enhance great contents, and it makes it very attractive to others. So this starts not with your tweets, but also with your picture, with your background. Make sure you have a picture that's high resolution, a picture of you that's approachable. So you have to be smiling, or you have to be your normal self, so that people would want to follow you. And have a background that's of relevance to either what you do or to an event. You could change your background as necessary, because sometimes there are things that you wanted to highlight in your background. And your bio also has to be very clear about you. It doesn't have to be very extensive. Please have 3 or 4 things in your bio that tell people more about who you are, so that it can enhance your followers. Authenticity, always be yourself. Everyone else is taken, so you can only be yourself. Your content, this is the crux. It has to be relevant, and it has to resonate with others. Otherwise, no one is gonna follow you or interact with you if contents are lacking substance and are not relatable. Back to aesthetics, use photos and videos to enhance your tweets. They're not absolute, but if you can always add them. It makes it more appealing visually, and it makes it easier. A picture is worth of 1,000 words. And be consistent. We get busy in our lives and our busy works, and that's okay, but try your best to be consistent as much as possible. Responsiveness, respond to others. If you've tweeted something, someone asks you to elaborate or ask a question, or offered a viewpoint that's different than yours, be responsive to that and stay professional. Steer away from major disagreements on Twitter. Clearly state your viewpoint and respectfully disagree, but don't engage into a lot of back and forth. I've heard some people say 3 strikes and you're out. So you could try to relay your message, but don't keep going on and on and on. So the final part that I wanted highlights some of these aspects on how you actually do it, and a sample tweet is by no means comprehensive or exclusive. This highlights the role of pictures and graphics, which is beautifully done, and this is done professionally by Jack, exemplifying diagnosis of ATTR amyloid cardiomyopathy. And you can see here a picture, a few information displayed, very clear, 2 of the experts being tagged and the article being hyperlinked. So this is a great way to get a tweet out. The second revolves more around education, and this is providing pearls and pitfalls. This is geared more towards trainees, and it basically say what should be done wrong, right, and how it was done wrong, and doing this in a very succinct way. Third example is using polls, and this is mentioned by Needy and Jordan earlier today. Polls are huge. They're very popular because it's one click, it's interactive, it's very stimulating. So feel free to use them for you to learn or for you to get others' input about something that you know, but you don't know what other viewpoints exist. GIFs and along that line, videos are also a great way to enhance your tweet. This is a GIF that illustrates cardiac cycle and cardiac anatomy at the same time. Is very interactive. It could be used again in medical education. And real stories, sometimes all you need is simply a story. If you're comfortable to share your story, this is highly relatable. People relate to it. And it has a purpose and a message to convey that's related to patient care, related to specific interests. And it's very authentic, very, very genuine. And this is something that's highly popular, as you can see, from the number of free tweets and likes. So in conclusion, Twitter is here to stay. Harness its power to your advantage. Join soon if you haven't yet. And if you're afraid to jump on, start tweeting, just start by reading, sit in the background and take your time before you dive deep in. Follow those who inspire you and learn from them. Be yourself, be authentic, be professional, and the final word is to be kind. This is not a place where you would want to create enemies or want to be disrespectful to anyone's opinion. Everyone is entitled to their opinion, and everyone should feel free to share what they wanted to say, as long as it's professional. And with that, I conclude my talk. Thank you very much.
Thank you, Selma. Great tips on clinical practice across Twitter, and I liked your tips about when to tweet. I have a colleague who sends out mass emails to all of our group at 6:30 in the morning because he knows that that is when we have a captive audience. And so I think similar rules apply to Twitter. So next I'll have Dr. Amit Patel load up his slides here. He's a cardiologist at the University of Chicago and is the director of the cardiac MRI and CT programs. He'll be giving a talk here entitled Establishing Yourself as a Sarcoid Imaging Expert. Dr. Patel.
Great, hi, good afternoon, good evening, everyone. My disclosures are listed. So I'm gonna start by saying, hello, I'm an expert, and then maybe try to define what that actually means. According to Merriam-Webster, it's one with a special skill or knowledge representing mastery of a particular subject. I think it's should be considered in the context of something referred to as the Dunning-Kruger effect, which is a cognitive bias in which people with low ability at a task can overestimate their own ability. And this is just a graph showing the relationship between confidence and experience. And when you have very little experience, you can have a lot of confidence. However, as you get more experience in a field, you can see you have less and less confidence as you try to start to understand all the caveats and ifs, thens, and buts, and other things that are just not clear. And in fact, even when you are fully an expert, you may notice that your confidence level is much lower than someone who was inexperienced to begin with. And over in the modern era, our kind of thinking about expertise has changed over time, and healthcare is no different. A long time ago, leading scientists were considered to be the real experts. As that information could be disseminated to their students, students became experts. And then once the 24-hour news cycle era arrived, really journalists were the ones that were looked to be as experts. And then now with the democratization of information and just the widely available ability to access the internet, really anyone can become an expert on Facebook, and perhaps Dr. Google is the key person. And today even politicians can claim to be experts. All of kind of this change that's been happening, this as information has become more and more accessible to the masses, there's been a trend of kind of the death of expertise that's been happening. So what is sarcoidosis? And I guess the focus of the talk was to become an imaging expert in sarcoidosis. However, I think with a rare disorder like sarcoidosis, you can't just be an imaging expert. This is a rare condition, multi-systemic. There are not that many experts on the topic area, and so you really do need to understand more than just imaging, because you may be the only expert. Currently, the etiology of sarcoidosis is not well defined. At autopsy, we as cardiologists are interested because about 25% of sarcoidosis patients do indeed have cardiac involvement. The presence of cardiac sarcoidosis is associated with increased mortality, and that's why we pay so much attention to it. And the treatment of it with steroids or ICD implantation can really lead to improved clinical outcomes. But we have to also remember to understand a little bit about neurological complications, the impact of lymph nodes, the lungs, the liver, the skin, the spleen, joints, the eyes, and all the other kind of organs that are affected. Now, sarcoidosis is a granulomatous disorder, so the differential diagnosis of this condition includes a whole bunch of things that maybe we as cardiologists don't think about often: infectious causes, occupational and environmental exposures, a variety of neoplasias, and a bunch of other autoimmune disorders. And then the pathophysiology of this condition is very different from our usual heart failure. We need to understand, or try to understand, the immune system, the role of T cells and macrophages. And finally, the medications that are used to treat this condition are definitely ones that are not your typical heart drugs. So we need to learn them. We need to understand some of their side effects and then how to monitor for them. And all of this in the milieu of the fact that there really isn't any huge number of great randomized controlled trials that tell you this is the right thing to do or that is the wrong thing to do. You have to have experience. So how do you become a sarcoid expert? So step one, you have to know the literature. So here's just a couple of search terms on PubMed. Here I searched cardiac sarcoidosis, and there was nearly 3,000 hits. And if you do just sarcoidosis, there's over 30,000 hits. And you can see the exponential growth in information that's occurring. Now, obviously, you cannot know all of these articles. However, you certainly have a wealth of information that already exists that you need to try to understand. in addition to that, it's important to try to understand what's coming up in the future. And so here we can maybe set up Pubmed Alerts so that whenever something like cardiac sarcoid is published on, you get an email, or you can follow these Twitter bots. Here's an example of sarcoidosis paper, and it tweets out a link or a notification of any time a paper comes out. To be an expert, you also need to really know the guidelines and consensus expert documents that are out there. And there are a bunch. Here's an example of one published by the Heart Rhythm Society, which looked at the role of advanced imaging to help you decide which patient should get an ICD and what type of imaging may be helpful. Here's another one published by ASNC, and here really talking about when you might choose to do a cardiac MRI versus a cardiac PET scan, and kind of what the downstream implications of your findings might be. Now, we're imagers, and what we bring to the table is a background knowledge of imaging, and sarcoidosis as a condition really is well suited to use multiple different imaging modalities. And our patients, they're getting SPECT exams, they're getting cardiac MRIs, echoes, PET scans. And so we really need to try to understand the strengths and weaknesses of each of the imaging modalities. We need to understand what biological process are they really telling us. And we need to then decide for this particular moment, for this particular patient, what is the right imaging test to perform to help us. Now, it's important that I think, especially in a kind of a complex disease such as sarcoidosis, that we're not a hammer looking for nails. We really need to have a toolbox of things to use to do what's right for our patients. So just here, kind of an example of why imaging is so helpful here. In sarcoidosis, there's really a complex relationship between myocardial inflammation, myocardial scarring, and myocardial remodeling. And so the cardiac MRI maybe can show you fibrosis, PET scan can show you inflammation, and then an echo is almost always utilized in sarcoidosis because it's widely available and does provide a wealth of information. So the next kind of step in becoming a sarcoid is to really learn about the clinical issues and challenges. And I think for starters, as imagers, we may want to, we should review and discuss the images with the clinicians taking care of these patients. And I think by doing that, we will start to learn and understand what exactly it is that the clinician wants to know. And beyond that, we may, because we know the imaging so well, we may be able to provide new insights that we didn't realize could be provided. If you're able to be part of a team who's interested in sarcoidosis, I think that's very beneficial. Just from within cardiology, you may need an imager, you may need a heart failure specialist, you may need an electrophysiologist, and then there's the pulmonologist, rheumatologist, neurologist, and the list goes on. And really, would not be easy for a single cardiac imager to know all of the things that this whole group of people could possibly know. I think another thing that we can do is discuss these complex cases with experts. And certainly we can use a variety of social media, Twitter, Facebook, Doximity, LinkedIn, YouTube, WhatsApp. But I think one of the more useful social media sources are actually the sarcoidosis listserv created by ASOG, where it's really for clinicians and research and really in-depth discussions and case presentations of actual patients and physicians struggling to figure out what's the right thing is happening, and you can learn a lot from that. And perhaps more importantly, we can learn from the patients. We can engage with foundations such as the Foundation for Sarcoidosis, the Bernie Mac Foundation, some of the Facebook sites that were described earlier today. I think all of these things can help us. So when I first arrived at University of Chicago, one of our major referrals was to evaluate for cardiac sarcoidosis and for cardiac MRIs. And just as a quick observation, I noticed that many patients would have a normal ejection fraction. They would have a little bit of late gadolinium enhancement. And it was the electrophysiologist in response to this finding would oftentimes place a defibrillator. And so we tried to understand how often this was happening and if it meant something. And so we created a registry. And what we found was that actually 20% of patients with normal ejection fraction had cardiac involvement, and only half of these patients would have been identified by traditional means. Okay, so the next question was, all right, this is happening relatively commonly, doesn't mean anything. And so we kind of expanded our follow-up and monitored patients over time. And what we found was that those patients who had no late gadolinium enhancement, their prognosis was really excellent. However, those that did have late gadolinium enhancement, despite having a normal ejection fraction, they had a lot more ventricular arrhythmias and other important cardiac events. But we were also able to elucidate that patients who needed to have a certain amount of late gadolinium enhancement or myocardial damage before their risk started to improve. And if they had RV dysfunction or heart failure, these were important covariates that really help define a patient's risk. So the last step in becoming an expert is to see lots of patients and learn from them each time. And so here is a 38-year-old man with palpitations. His EKG shows non-sustained ventricular arrhythmias. This is his MRI. You can see the late gadolinium enhancement in the septum, here in the anterolateral wall, the inferolateral wall, the anterior wall, the inferior wall, really all over. The MRI very suspicious for sarcoidosis. His PET scan shows FDG uptake in the lymph nodes and throughout different areas of the left and right ventricle. He received a presumptive diagnosis of cardiac sarcoidosis. And he was referred for an endomyocardial biopsy and a lymph node biopsy, both of which were negative. He was empirically started on prednisone because we felt the imaging was very consistent with sarcoidosis. He had a repeat endomyocardial biopsy guided by electroanatomical voltage mapping, which did not reveal a diagnosis. And then he had a fourth biopsy, this time by VAT thoracotomy, which finally confirmed the diagnosis of cardiac sarcoidosis. So what did we learn from, and so here, just an example of his baseline images. After treating him with immunosuppression, you can see the inflammation is gone on the right, and the late gadolinium enhancement is present, but a little bit less. So here's his initial ejection fraction. You can see it's severely reduced, and with treatment, it's mildly reduced now. So as we continued to follow him, he started to have more ventricular tachycardia, which in the end was treated by ablation and ICD implantation. And so all this clinical experience kind of raised several questions for us. First, how often is cardiac sarcoidosis present in patients presenting with ventricular tachycardia? So we took a cohort of 67 patients and they underwent both MRI and PET scanning. And what we found was that 2/3 of the patients had late gadolinium enhancement, and those patients who had late gadolinium enhancement, about 10% of them were FDG positive with a strong suspicion for cardiac sarcoidosis. So you can see that indeed for a patient with ventricular tachycardia who don't have any other obvious indication, the diagnosis of cardiac sarcoidosis should definitely be considered. And finally, we asked what's the right time to, well, we didn't ask, we were curious about what the right time to ablate was, and Dr. Carr and colleagues actually published a paper that just showed us that, where if you divided sarcoidosis patients into those who are in the inflammatory group and those who are in the scar phase, the patients in the inflammatory group actually only had a successful ablation a little over half the time, whereas if you were in the scar phase of the disease, your success of ablation was much greater. So this is just an example of how you see a patient, you ask questions. If the literature is not out there, maybe you try to answer it yourself. And if not, you find the literature and answer the question, and you're always kind of updating your learning. So I think that's how you become an expert in sarcoidosis. It really involves seeing a lot of patients and a lot of homework, and social media certainly has a role to play in helping. Thank you very much.
Fantastic. Thank you, everyone. Great talks. I'll ask everyone on the panel to activate your video here for some couple more minutes here for question and answer. And I have something that I've been thinking about a lot and has come up on several of the talks here, and goes with the theme, and I'd like to see what our panelists think. So, you know, as social media use increases with physicians and is starting to, you know, supplant some standard research activities, what do people think about getting credit for your social media use with respect to academic advancement and bonus and everything that goes into your metrics, you know, as a physician? People are publishing cases on social media instead of doing case reports. There's even on Twitter been some meta-analyses that have been published very quickly, as opposed to sending it to a journal, you know, as soon as another paper comes out. And we saw this recently in the past few days with some of the SGLT2 inhibitors. So what do people think about that? How can we use our social media presence for our academic existence?
Yeah, I guess I can start here. I don't necessarily think that social media is ready yet for prime time for consideration for promotion. And I'll say that for a couple of reasons. You know, one of which is it's not peer reviewed. And so it's easy to produce content, but that content isn't necessarily policed in any kind of way. And so the peer review process, I think, has a certain, there's a certain rigor to it that I think you don't get necessarily. That said, I think social media and getting involved in social media very much helps people's underlying career, in part because, for example, if you publish a paper, broadcast it on Twitter, you get a lot more views, visibility, etc. with that paper. You create connections and networks that allow you to be able to do collaborative projects that really would not otherwise be possible. And so I think there, ultimately, at the end of the day, there is some academic credit that you get for it. It's just indirect.
Mm-hmm.
And Brett, I can make a comment too. So at the Mayo Clinic, which is where I work as an institution, we do recognize academic work done through social media. It typically falls under a lower impact factor, but I think Mayo is kind of spearheading this effort where there is more recognition of it. The other thing is, I would agree with everything Jordan said. For me personally, I know social media has really helped me kick launch my career, and I've got several publications on social media itself that I might not have normally gotten. And of course, I've met hundreds of people on social media. My network has grown immensely, and I'm collaborating and writing manuscripts with them. So all of that actually counts, but it doesn't count directly.
I agree with Niti and Jordan that it's not ready for prime time, and it's something that's in the future, definitely. There is going to come a day when we'll have to face the challenges that relate to lack of peer review for material in social media. But more importantly, also, how do you place a value on a specific activity as compared to another activity? I think this will be the hardest part for us to come up with fair metrics that could be followed, and this way it's a comparison of apples and apples, not apples and oranges.
Thank you. Other thoughts on this topic? I have one more question, and then we probably will have to end it there. So the last thing I wanted to ask some people, and this was again talked about in a few talks, but we heard a lot of the positives about social media, right? But there are obviously some negatives. How how does everyone monitor their use of social media, iPhone, so that it doesn't dominate your life? Do people use the screen time apps for iPhones, or do you have guidelines for yourself as far as how much time you will use social media and how much time you will not use social media?
I can take that one.
Mm-hmm.
So for me, it comes in ebbs and waves. There are times, like during ASNC 2020, where I just know I am going to be addicted to my phone and Twitter, and there is no way around it. And I'm I've spent a lot of time on Twitter already this morning and yesterday, and that's going to continue. But then there are going to be periods where I may not look at Twitter for 2 days in a row. And then every 4 months, at least prior to the pandemic, I was very good about doing this, but every 4 months, I try to force myself to go on a vacation, perhaps for hiking or something of that sort, where I have no internet access for a 24-hour period. And that forces me to connect out from the internet digital era and go back to normal real life and reset my mentality. It's been a little bit harder to do that with COVID and kind of being stuck at home and having internet all the time.
I take a pretty different approach to it. I found, like everyone else, I'm sure, that Twitter can and social media it can become a very time-consuming, addictive activity. So I actually only rarely go onto social media at all now, the opposite of what this panel is doing. But if there's a paper or something that's interesting, I'll get on and try to see what people are talking about. If there's something I want to search, I'll go there and search on it. But I won't let the information just come at me because there's lots of ways to get information at you, and I think you can go down a lot of rabbit holes once you get onto social media, and so and I'm not sure everything is all that helpful on social media, though some things are very helpful.
Great. Brett, it looks like we have a question for Tanis.
Yes, Tanis, and there's a question in the Q&A here about the limitations of content posting on social media, and I think that that maybe that's has to do with how do different people manage posting personal information from a patient standpoint, limitations with that respect, and just even some of the negatives that you see on social media with respect to patients. We see a lot of anecdotes now with COVID, and you hear positive stories and then negative stories, and I'm sure that can create a lot of anxiety, and you probably hear many anecdotes in your patient groups as well. How do you manage all that?
So as an admin in both the cardiac and the sarcoidosis women, they're both private groups, and also we screen who we allow in, and we also screen every post. So we don't allow anything that honestly isn't from FSR right now. That's the rule that we have. So if we're sharing any kind of article or anything like that, we really check it and make sure it doesn't have any links that are false or dangerous. So we really see our role as an admin to protect the women or the people in the group. So we can do that, like I said, by not allowing them to post directly, but we have to monitor everything that is posted. We also don't allow them to give each other medical advice. Mm-hmm. We encourage them to share stories and support, but we don't allow any questions regarding actual medical advice. We tell them to speak with their doctor about it.
Fantastic, thank you. Well, I'd like to close up here to be respectful of everyone's time. It's 4:34 Central Time and 5:30 Eastern Time, and so thanks everyone for joining this. Thanks to all of our speakers, our panelists. And we will sign off for now, and we'll see you at all the other amazing ASNC 2020 events over the course of the next few weeks. Take care.
Thank you.